Okay, good evening, everybody. Welcome to this another session of 50-second comprehensive course on echocardiography. We have come a long way after learning from the basics of MO, 2D, and Doppler. We started with valvular lesions. In the valvular lesions, what we have done till now, we have looked at all systems consisting of mitral stenosis, aortic stenosis, tricuspid stenosis, and pulmonic stenosis. Now we are moving on to the next session, that is mitral regurgitation and aortic valve regurgitations. They are again the applications of technology which we learned with the basics of echocardiography. Well, I'm Dr. Rakesh Gupta, who I'm going to teach about this particular session today, that is on mitral regurgitation as well as aortic regurgitations. And as usual, I'll take my questions the last so that you can understand it very well. And majority of you must have been getting the video recordings of all these sessions, which we have been doing for almost now 2 months down the line. We started on 24th of September. It is 26th November today. With these few words, let me switch over my presentation from the present slides to mitral regurgitations. Well, the most important part for any mitral regurgitation to begin with is how does the valve leak? How much is the leakage? How do we decide about it? And what is the prognostic value? Well, if you look at this chart very carefully, till the patient develops the symptoms, everything looks good. The patient's onset of severe mitral regurgitations, progressive LV dilatations, LV dysfunctions, onset of symptoms. And when we look at all these things together, the most important thing is what? The first important thing is LV dilatation. It means to say that if a patient has got a severe mitral regurgitation, if LV starts dilating, it means something wrong has happened. And the prognosis becomes further bad when the dysfunction starts happening. Just a minute, can I hold on for a second over here? Give me a sec, just needs. So once the LV dilatation starts happening, and that is the worst point anybody can have it. And it has to be an indexed value, 32 millimeter end diastole, 22 millimeter end systole. Anything more than that is abnormal. And if you look at this slide carefully, the day symptoms appear, the fall is dramatic. So quest is, we have to pick up these subjects well before the LV dilatation happens. Even if the LV dilatation has happened, LV dysfunction should not happen. Now, let's move on. That's why we need all these evaluations in a perfect way. Then question is, what is the anatomy of the mitral valve? Well, all of us, we understand a mitral valve consists of two AML, anterior mitral valve leaflet, and posterior mitral valve leaflet. Then it has got two commissures. One is, people say, anteromedial, second is posterolateral. I always never say that. I say medial or lateral commissure, straightforwards. Then apart from this, the leaflets of the AML and PML, they're attached to papillary muscle through cords, which we have learned during our medical times. The cords which are attached to the primary leaflet or the tip of the leaflet, they are known as primary cords. The cords which are attached to the body of the leaflet, they are known as secondary cords. And that is very important when we look at these primary and secondary cords. Now look at the classification. There are multiple classification available based on etiology, timings. And what is the classification is? Primary versus secondary, Carpentier classification, acute versus chronic. Why we say acute versus chronic? Because if a patient develops a papillary muscle rupture, this is acute phenomenon. If the patient develops a severe mitral regurgitation secondary to rheumatic heart disease, it's a chronic mitral regurgitation. And Carpenter is used because he's the person who helped us in identifying the various etiopathogenesis of mitral valve abnormalities. Let's start one by one. Apart from that, we have certain special interests. One is myxomatous valves. I'll show you what is myxomatous valve is. Then we have a degenerative valve. This has played a very significant role in day-to-day practice of ours. Believe my words, we are getting more degenerative mitral stenosis and regurgitation than rheumatic heart disease as on today. Then, talking of a dilated annulus, ruptured cords. And this is again, a scenario has changed. Now, if you have a dilated annulus, you have a severe mitral regurgitation, we talk of a invasive mitral collapse as a correction process. And recently I saw one of the ruptured cords being tackled by the mitral collapse. Let's move further. Then quantification of the mitral valve leaflets. There was a time when you used to have angiography. Now is hardly done as on today to assess severity of the mitral regurgitations. And mainly this evaluation is done by transthoracic echocardiography. Every one of us can do it. You can do it. Like I can assure you, 70 to 80% diagnosis of mitral stenosis regurgitation can be done by all of you by transthoracic echocardiography. And only 20% where we need additional modalities. And look, how do we do it? First is, what is the cause of MR? The cause of MR will tell you automatically. Look, this is how we treat the MR. Then, if you have a severe MR, the velocity across the MR, velocity across mitral valve will increase automatically. Then jet area, LA area, which all of us have been reading for a long time. Jet area and LA area. Then vena contracta. Then flow reversal in descending aorta, pulmonic veins, which is a very important parameter as on today. Then pizza-derived mitral regurgitation orifice area and regurgitation volumes. Then regurgitation volumes by continuity equations. And as I said in the beginning, LV internal dimension during diastole and ejection fraction, LA volume indexed, and LA volume, LA dimensions. This looks to be very cumbersome. Believe my words, when we start doing it, it becomes very simple. Now, here is a patient of mitral regurgitations. So what will happen? If you have a severe MR, the flow across the mitral valve will increase. It was a normal phenomenon. If so many people are coming back to your hall, once they go out, obviously the number would look to be high. So that is one of the semi-quantitative measurement of mitral regurgitations. Normal velocity up to 1.3. If it's more than 1.3 and if it's more than 1.5, it definitely makes a lot of difference. Then the Doppler signals. Look, if it's full, it means the lot of blood is going back in the regurgitation volumes. Look at the previous slide. There's some emptiness is seen over here. But the lesion is holosystolic. Complete systole is being occupied by regurgitation lesion. And when you have this full thing, it means a lot of mitral regurgitation is happening, again suggestive of possibly severe mitral. They are qualitative, they're not quantitative. And another factor is when you have MR, just put a continuous wave Doppler across it. Pick up a velocity and peak velocity of the MR. And you know how many peak velocity should be there in MR in a normal subject? At least 5 to 6 meters per second. Why so? Consider my LV pressure is 120 and my LA pressure is 10. What is the gradient? 110 millimeters of mercury. For calculation purpose, let's make it 100. If you divide 100 by 4 and square root of it, it'll be 5 meters per second. 5 into 5 into 4, 100 millimeters of mercury. If you have a less gradient during your evaluation of MR, take my words, your LV is poorly contracting. Do it tomorrow. You will realize the fact patients who have got a severe mitral regurgitations, they have a dilated cardiomyopathy. You can assess their blood pressure. You already know how to assess your diastolic. We have not taught you as yet, but suppose your LA pressure is 10, which is normal, and you have a MR jet velocity of just 4 meters per second. So your blood pressure would be 4 into 4 into 4, 64 plus 10, 74 millimeters of mercury. And that is what is very important when we look at the MR jet velocity. Now, third important thing is my jet Doppler spectrum pattern is almost always tongue-shaped. When it acquires a sharp acceleration time and slow deceleration time, it means it's severe. Now look at this Doppler spectrum pattern and let me go by. It is still not rounded shape, but somewhat unrounded shape is. But look at this is sharp acceleration time and this is a slow deceleration time. And when this happens, this itself tell you, look, we are dealing with severe mitral regurgitation. So these are the things which helps you in making just the Doppler spectrum about your severity. That tells you that something wrong is happening with this patient. Let's move on to other things, like what we do is we assess quantitatively of MR. Color velocity scale is about 5.5 meters per second. What does it mean by? Now, if I look at my color Doppler spectrum pattern over here, this is my Nyquist limit. This Nyquist limit on either side should be 50 to 60 centimeters or 0.5 to 0.6 meters per second. And this Nyquist limit you can adjust in the machines. And that is very important thing is to keep your Nyquist limit between 50 to 60 centimeters per second. Parameters, jet area versus LA area. And you have to use multiple planes because the jet of MR does not come in one direction. It can go in any directions. Then planimetry of the whole jet area, calculate in the same cardiac cycle, mild less than 20, moderate 20 to 40, severe more than 40%. Area of the regurgitation jet, better correlation with angiograms, mild, moderate, and severe. Let's show how do we do it. First is jet area, and this is everybody has been doing till date. And believe my words, I hardly do it. I'll tell you why I hardly do it. So what do? We look at the jet regurgitations. Then as soon as we see a jet in systole, we trace the jet area in the systole. Remember 4, remember 8. Less than 4, more than 8. That is mild or severe, somewhere in between is moderate. And area is always in centimeters. Then second is, we look at now look at this patient. I'll hold it if I can hold it. Look, this is an eccentric jet which is hugging along LA free wall. And this jet is, if you look carefully, this jet is going back up over here. Correct? So if I calculate this jet area, I'll be underestimating it because it's eccentric. One. Second, this jet is dependent on what? It is dependent on driving force of LV. Suppose my BP is low, I'll be underestimating my MR jet. Suppose my LA pressures are high, as in this patient, LA is large in size. LA pressures are more than 10 millimeters of mercury, I'll be underestimating it. Similarly, if my BP is very high, I'll be overestimating my MR jet. So it gives you a qualitative or semi-quantitative measurement of mitral regurgitation. You may have a patient of a severe MR, but you look at that MR will appears to be mild when we have this kind of abnormality. When LV is poorly contracting, LA is huge. So it will tell you roughly what is my severity of MR is. And based on this, we never judge as on today what is my severity. As I said a few minutes back, large LA, atrial fibrillation, poor LV systolic contraction, raised LA mean pressure. They are the pitfalls in jet area assessment. And if you increase the NICUS limit from 50 to 60, like over here, I'll be underestimating it. If I reduce to 40, I'll be overestimating it. That's one jet area. And believe my words, if you happen to look in a medical college or a hospital or a center, they will not do anything, just switch on a colors and look how much is jet, 1/3, 2/3, 3/3, mild, moderate, severe. And they are done. All right. Now, MR has to be holosystolic, early systolic, mid systolic, or late systolic. If it's small jet, just an early systolic. Mid systolic, click with MR. Always think of mitral prolapse syndrome. Holosystolic, severe MR. And late systolic MR is when? Hypertrophic cardiomyopathy. And that's how we look at the timings of MR with the jets. Now, second area is you measure the jet area and you measure the LA area. That was 4, 8, in between moderate. Here is 20, 40, and in between is moderate. So one parameter was jet area, second parameter is jet area versus LA area. And now the most important thing which comes over here. We measure jet area during when? Systole. When do we measure LA area? Same during systole. Because during systole, the LA is gradually becoming bigger and bigger and bigger because it's a ghastly phase of LLAs. So that's one important thing. Now, important rigorous issues are when we have an area which is eccentric, then we add, as in this patient, we said if it's a moderate, we'll say large. And hence, some people, they classify MR as +1, +2, +3, +4. 1, 2, 3 for mild, moderate, severe. Add 1 if it's an eccentric jet. Third important point is a vena contracta. If you really ask me, what are the parameters to look for a vena severity of MR is, this is one is vena contracta. And remember, this is perpendicular. We are in Plaque's view. Let me show a pictorial diagram. We are not measuring four-chamber view. We are measuring in parasternal long axis view. So we are perpendicular virtually. And what do? We look at the distance through which the MR jet is happening between the two leaflets of the mitral leaflets. And the neck of these two leaflets, the distance of between these two leaflets. Let me show this picture over here. Now, look, this patient is in end systole, mid or end systole. How do you recognize? Here is the pointer, which is at the end of a T wave or just at the end of systole. Look, this is the color through which the jet is originating from mitral regurgitations. So this is a width of a jet, which shows how much is my vena contracta. Let's go back to picture again. So this is vena contracta, through which the narrow neck of a jet through which the MR is happening. And this is what we are measuring in long apical four-chamber view, mild, moderate, severe. And this is flow convergence. So we are measuring vena contracta at the neck during systole. When the LV is contracting, a jet is going back into the LA. Now this is flow convergence, vena contracta, and this is MR area. So most important thing, remember, you do a jet area, you do an L area, you calculate a ratio, but the most important thing is you should do a vena contracta. And vena contracta will always be in a plaques view, good plaques window, and start looking for a regurgitation jet which is happening through this two leaflet during systole and the Nyquist limit between 50 to 60. So third point, believe my words, I never use jet area. I never use jet area versus L area. The first thing, if I have to look, is I always look my LA, LV dimensions and then look for the severity of MR by vena contracta. Very simple, 3 and 7. Less than 3, more than 7. Less than 3 is mild, more than 7 is severe, and in between is moderate. So we looked at jet area, we looked at jet area versus L area, we looked at vena contracta. Very simple maneuver of doing evaluation of a severity of MR. I've seen many people doing in this four-chamber view, but in those cases, we are overestimating the vena contractas. It's not that we cannot, but we overestimate the vena contracta. Now look at this picture very carefully. I'm going to play it again for you. So jet is regurgitating. This is plaques view. The aorta is almost horizontal. And this is what it is. Zoom up this picture. Let me zoom up for you. I hope I should be able to do it. It does not go back. No, it's not going. Let's not do it. So just measure the vena contracta during systole. Look, this red arrow is over here in systole. Nyquist limit 50 to 60. This is 53, 55. And if you happen to measure my LV dimension, this is what I was saying. Basal interseptum, basal posterior wall. This is systole which is happening. Measure it in diastole. If it's more than 32 millimeter per meter body surface area, your LV is dilated. All right. Now, if I show you this chart, which was made in 2014 by AHA-ACC guidelines for valvular heart disease, let me just look at this. Vena contracta, more than 7.7 centimeters is severe. Jet area versus L area, more than 40%. Now we have multiple other things. Regurgitant volumes, regurgitant fraction, effective regurgitant orifice area, LA enlargement, LV enlargement, certainly yes. Peak pulmonary artery pressure, angiography code. I'm not really bothered about all this. What I'm bothered at your level is look at LV enlargement, look at the vena contracta, look at the jet area versus L area. And the most important thing comes the regurgitant volumes. And this we adopt to a very large extent in our clinical practice. How do we do it? It's a very simple method of doing is what is the method is we know what is LVOT. So we measure LVOT diameter in plaques view. Then we go to in 3-chamber or 5-chamber view, calculate your LVOT VTI. So what you will be driving out of this is stroke volume across LVOT. Now you go to 4-chamber view, look at the mitral annulus diameter. This diameter will give you radius, and with radius you can calculate the area of the mitral valve at the annulus level. Look, I did it at LVOT, I did it mitral annulus, mitral valve OT, outflow tract. Then what I did, I put a sample volume at the mitral valve outflow tract to get mitral valve VTI. Trace the VTI, and same thing I went to 3-chamber view to look for LVOT VTI. So what I was drawing out of this is LVOT area into LVOT VTI. That'll give me a stroke volume across LVOT. I went on to do a mitral annulus. Then mitral annulus gave me area into VTI. It will give me stroke volume across mitral valve. Now tell me what will happen. If you have a severe mitral regurgitation, the stroke volume of mitral valve would be much more than LVOT. Why? Because every systole is pushing blood back into the mitral valve, LA. And if the difference of this stroke volume across mitral valve minus LVOT is more than 60 ml, and that's what we say is severe mitral regurgitation. And it's pretty useful in day-to-day practice. Little cumbersome, LVOT diameter, mitral valve diameter. LVOT VTI, mitral valve VTI. Now look, let's get rid of LVOT VTI and mitral valve VTI diameters. Let's just look at mitral aortic velocity integral ratio. What is that? So what I did was, instead of doing an LVOT diameter or mitral valve diameter, I forgot about all this parameter. I looked at the LVOT VTI and mitral valve VTI and calculate the ratio of mitral aortic velocity integral ratio. If it's more than 1.4, it means I'm dealing with severe mitral regurgitation. Very simple. We started with jet area. We started with jet area versus LA area. We moved on to vena contracta. We moved on to regurgitant volumes and then volume mitral velocity integral ratio. And most important thing is LV dilatation. Another very simple method is, look, there's so many things are there. I'm not going to talk about level 2, level 3, or level 5, level 4. Let me just show you which is the most important thing. This is what LV dimension is. Plaque's window, this is calculated from a short axis view. This is not correct. Plaque's window and then LV ejection fraction. Normally, what will happen to ejection fraction? As the MR increases, if the LV starts getting dilated, my ejection fraction has to super normal. It's not like we are talking of 50 to 60. It should be 70%. And that is one reason when the ejection fraction falls means it goes below 55%. It is not because of that it has gone below 55%. It has gone from 70 to 55%, which unfortunately our guidelines does not talk about it. So, but when it's less than 52 or 54% in male versus female, then we call them as LV dysfunctions. All right. Next important point is a very simple human interference. Suppose I've got a severe mitral regurgitation. This regurgitation is hitting back into the pulmonic veins. So what will happen to pulmonic venous flow? Normally my pulmonic venous flow is more in systole, less in diastole, but it's a continuous flow. As soon as I develop a severe mitral regurgitation, look, there's a truncation of systolic flow and more flow seen during diastole. This is S, and ECG gating helps you. You can't do it without ECG gating. Take my words. And sometimes not even this, the flow become reversal. Not only truncation happens, the systolic flow will become reversal. Now think carefully what exactly this MR is doing to this pulmonic venous flow. It is during systole, whatever the blood which is coming from pulmonic vein is being hit by regurgitation flow. And this regurgitation flow obstructs the flow of a pulmonic vein to LA. So much so in severe, if the jet is very significant, it hits back into the pulmonic vein to do a reversal of flow in the pulmonic veins. And believe my word, this is the most important sign number of times when we look at the severity of mitral regurgitations. Your jet may look innocuous, But when you put a simple volume into the pulmonic vein, if its reversal is present, take my word, whatever the issue is, your severity of MR is severe. And look at this patient. There's hardly any systolic flow, is all reversed over here. And look at the diastolic flow, it's trying to compensate almost 1 meters of, maybe more than 1 meters of a flow velocity. All right. So we started with what? We started with transmitral flow velocities, increased. MR jet area, 4 or 8. Jet area versus L area, 20 or 40. Vena contracted by 2D, less than 3, more than 7 millimeters. Flow reversal in descending pulmonic veins, severe. Truncation versus reversal. Then regurgitation volume quantity equations, more than 60 ml. And mitral aortic velocity integral ratio, MAVER, and that is MAVER is more than 1.4. And even if you remember all these things, believe my words, you have done everything for mitral regurgitations. All right. So before I start taking a question, it's a very simple thing. You don't need a time. This is what is there in asymptomatic, severe, non-severe, or progressive mitral regurgitations. Now let me show you a couple of pictures of etiopathogenesis of mitral. Or let me save it for you. Now, first we talk of primary versus secondary. What do you mean by primary? There's something to do with the leaflet of the mitral valve, like myxomatous valve, mitral valve prolapse syndrome, leading to prolapse, flail, rupture, or elongated tongue. Degenerative, very commonly seen degenerative today, thickening or calcification. Degenerative means aging populations. Infectious, leaflet getting infected. Commonest is vegetations. May have perforations and develops an aneurysm. I'll show you a couple of examples. Inflammatory or infectious, same. Inflammatory majority of time is set for rheumatic heart diseases or collagen disorders. And then congenital, cleft, leaflet, or parachute mitral valves. Secondary is when LV dilates and the leaflet do not touch with each other. That is ischemic mitral pathology. Non-ischemic, very common thing which is happening today, dilated cardiomyopathies with normal coronaries. Annular dilatation is another etiopathy. Now, look at this patient very carefully. This is long, elongated mitral leaflets, hypermobile, giving rise to almost a flail mitral leaflets. Flail means the tip of the AML is billowing back into the LA. I can't show you the tip switch of a colors, but if the tip is going back into the LA, it means we are dealing with severe mitral regurgitation, and this is known as flail mitral leaflets. Another example, this PML is flail, and I'll show you a picture. And now, again, this leaflet is prolapsing back into the LA, and we have got a severe mitral regurgitation. Very clear. Now, this is the 3D depiction of this flail leaflet. Let me hold it for you. Correct. Now, This is AML, this is PML. Look, this AML tip and this PML tip, they're not co-opting with each other. When they're not co-opting, what will happen? The blood will constantly leak from this non-cooptation, and this is known as flail leaflet. If you happen to see this flail leaflet, believe my words, I'll stop it over there and say flail, AML or PML needs interventions. Degenerative. This is annular calcification. This is medial annular calcification. Majority of them is lateral annular calcification. This is annulus calcification. This medial calcification is secondary to radiotherapy in CA breast patients. Otherwise, you'll find lateral and over here a calcification. This is mitral annular calcifications. This is degenerative flail leaflet. Calcification, degenerative, and the leaflet becomes flail. Again, degenerative, thicken, and apical hypertrophy. Infective. If you happen to see this ball on this valve leaflets, this is fungal endocarditis. This is a proven fungal endocarditis. Vegetations, like they look like a torn billboards on the airports. Shaggy, dirty looking, irregular shape, fimbriated, finger like projections. Whatever you can give your name, they are infective endocarditis. Do they need assessment if they've got a MR? I don't think so. We need assessment. Stabilize them, replace the valve. Now, again, example of healed calcifications. You can see AML, you can see, aortic valve and mitral valve. This is perforation of the mitral leaflet. Look, the jet is, or the coaptation line is over here, severe MR. But at the same time, you see another jet originating from the AML. And if I see this picture, they are virtually from our own labs. Like we have not borrowed them from anywhere. And this is what is needs surgery. That is what the difference when we look at etiopathogenesis. Patient of vegetations now has developed aneurysm of the AML. Again, severe MR, surgery. Now the blood is going back into this aneurysm. If it's an abscess, you will not see any blood into it. Then this is very unusual variety, quite commonly seen. Look at the mass in the apex. Very well contracting apex. Masses on the mitral leaflet, severe mitral regurgitation. You know how much is the platelet count? In lakhs. Then valve dehiscence. We are not going to talk about valve dehiscence at the present moments. Now, this is valve dehiscence in a prosthetic mitral valve leaflets. Let me just play it for you. Although, like the regurgitation jet is happening outside the leaflets. And this is three-dimensional picture. If I, this is just to show clarity because I'll try to hold this. Look, this is the valve. Here's the leaflet from outside. It's just leaking. This is prosthetic valve degeneration. There were three studs were present. One, two, and third is gone. This is prosthetic valve degeneration. Inflammatory, I'm sure all of you have seen this rheumatic heart disease. Thickened calcified mitral valve leaflet, doming in diastole, that's rheumatic heart disease. Congenital, look, this is a cleft AML. This is three-dimensional picture. This is lateral commissure, this is medial commissure, this is cleft of the anterior mitral leaflet. Parachute mitral valve. Both the leaflets of the mitral valve will attach to single papillary muscle. There's only one papillary muscle, not two. One is lateral, one is medial. Medial is not seen. Ischemic etiology. If you develop an anti-wall MI, you get a severe mitral regurgitation. We don't need to correct mitral regurgitation. We need to correct acute MI. Ischemic. No focal wall thickening abnormalities, but there's a lateral wall ischemia, papillary muscle dysfunction, and severe mitral regurgitations. So etiology tells you what exactly and how to treat these subjects. Non-ischemic dilated cardiomyopathy. Believe my words, very commonly seen nowadays in diabetic patients. Atrial fibrillations, both annulus gets dilated because atria gets bigger and bigger in size, LV and RV remains same in size. And how do you differentiate atrial fibrillation is normally LA is bigger than RA. In AF, LA and RA would be almost same size with normal LV, normal RV size and functions. This is what I wanted to say you the Conda effect. I just described this Conda effect a few minutes back. This is the jet of MR is originating from mitral valve, regurgitating back all the way back to the apex. Now look at carefully what do I mean by Conda effect. Now look at this jet. This jet is going back blue and now is red in color. There's no reverse flow from the pulmonic vein. I showed you a few minutes back. Look at the jet severity is going back. And I showed you the slide previously also. There's almost a reversal of flow in the pulmonic systolic flow. A lot of diastolic flow is present. This is what when we talk about etiopathogenesis by Carpenter classification from surgical purposes. We always write type 1, type 2, type 3. What is the importance of this type 1, type 2, type 3? When we say normal leaflet, excessive movement, restrictive leaflets. Normal movements, when we have, like I showed you an example of infective endocarditis with perforation. Similarly, if you have atrial fibrillation, leaflets are normal, but annulus get dilated. So both the treatments are different. I'll say type 1 needs surgery, like perforation, needs immediate valve replacement. In atrial fibrillation, we are not going to do anything. Just manage it. On the other side, go to restrictive leaflet. Most common thing is rheumatic heart disease or ischemic or dilated cardiomyopathies. And excessive movement is always myxomatous valves. Thin, long, elongated. You must have read a Marfan syndrome in your time of your post graduations. Like long, thin, elongated leaflet, more than 27 millimeter in size. And when they either quat, the body will prolapse or the leaflet will prolapse. So whenever you write, like we always write, if we have a like diagnosis, I always say like whether my patient of MR belongs to type 1, type 2, type 3. How do I remember? Normal versus restrictive. And second one is excessive leaflet movements. Acute versus chronic, multiple reasons are there and they're pretty common in day-to-day practice. Let me show you a couple of examples. Ischemic, I showed you a few minutes back. Then myxomatous, I showed you already. And why we need all these things, I said a few minutes back. If it's a myxomatous, medical management versus MitraClip, degenerative, surgical repair versus replacement, and others like we need dilated annulus with the MitraClip or ruptured cortex. During your medical college, you must have learned acute MR, non-adapted LA. So what exactly happens? The conditions where my LA, LV are normal in size, but my heart is suddenly exposed to a lot of blood. So what's the presentation? These people, they present to casualty with acute LVF because the LA is not able to adapt them. And when LA is not able to adopt them, all the pressure is being shifted to lungs. Normal LA, normal LV, almost normal LV systolic function. But left ventricular and diastolic pressures have gone up. If you put a pulse wave Doppler spectrum pattern to the mitral valve, you find type 3 diastolic dysfunctions. On the other hand, chronic, your LA and LV, they become bigger in size. The compliance, the LV start dilating, start accustomed to those severity of MRS. And that's how we look at this acute versus chronic mitral regurgitations. I couldn't load one picture today because what I was looking for degenerative mitral valves. Let me look if I've got some pictures of the degenerative mitral valves because I have been reading all the times degenerative mitral valve is giving rise to mitral stenosis. But I saw a patient where degenerative mitral valve was giving severe mitral regurgitations, moderate to severe mitral regurgitations. Let's start raising your hands. And meanwhile, let me just find out that patient of a degenerative mitral valve. I did load it here. I think I did load in my echo pack because that is one variety which is fortunately and unfortunately is very commonly seen nowadays. And we are finding more and more people presenting with this. At one time, we were looking at this aortic stenosis being degenerative. Now we are looking more of these people presenting with degenerative mitral regurgitations, apart from usual stenosis. So let the echo pack get going, and meanwhile, let me start taking a question. The first question is from Dr. Anu, roll number 33.
Yes, sir. Good evening, sir.
Good evening, Anu.
So, I have two questions actually.
You can
It
ask
is
me
on
five. I have absolutely no restrictions for questions. I'll be happy. Go
uh,
ahead.
from the very earlier slides from today's topic. I didn't quite get what is actually the Nyquist limit and
Oh,
what is its role in the color velocity.
I'm
The
coming back to the slide.
Yes.
You can see my slides.
Uh, so not right now.
They'll be coming up very quickly.
Yes, yes, sir.
Look, this is what the Nyquist limit is. What is the advantage and disadvantage is whenever we look at these colors, we have to adjust this Nyquist limit between, look, it's 0.64, 0.64 on upper side and lower side. It means it's 64 centimeters on either side. The blood towards the transducer is 64, away from a transducer is 64. Suppose I increase this Nyquist limit, I'll be underestimating my color flow velocities, color flow jet. If I'll reduce this Nyquist limits to 40, from 60 I make it 80, I'll be underestimating. If I reduce to 40, I'll be overestimating it. So that's what is important thing is. When we talked about basics, we said one important thing is the blood towards the transducer is red in color, blood away from a transducer is blue in color.
Yes,
Correct?
sir. Yes, sir.
So now remember your sequence of a colors of a rainbow. Violet, indigo, blue, green, yellow, orange, red.
Yes.
So what exactly happens from this point to this point? My velocity is 64 centimeters per second. The if the color further changes, it goes to opposite sides to blue.
Yes.
I don't have that slide right now in front of me, but I could explain you. That important thing is because that Vibgyor is, and just remember this slide is, you have to keep this Nyquist limit between 50 to 60 on either side. I'll write down your question. I'll answer you in the next of my sessions. Uh, a Nyquist limit. And if you just wait, I think I'll stop sharing, and if I get my Echo Pack ready. I think so. Echo Pack is ready. Yeah. All right. Oh, yes. I'll try to show you what you were asking. Give me a second.
Okay, sir.
Let me look at some severity of MR. Write down these questions and ask me when we are doing this live demonstrations.
Okay, sir.
Let me try if I can increase my or reduce my Nyquist limit. Mhm. I don't think so. I can do my Nyquist limit changes in this recording. Not really. So this is an inherent phenomena of machine itself. So what I can say is, like, just for the timing, remember this point 50 to 60. When I'll do a live demonstration, ask me this question again. I'll show you how does it make a difference. If I reduce this nicotinamide from 53 to suppose 40, so this color would be overestimated. This MR jet will become more. If I make it 80, the MR jet will be less.
Sir, I still didn't get what you told about overestimating and underestimating the.
Uh, I think at this point, I can only tell you, like, just remember between 50 to 60, and
Okay.
just drop me a WhatsApp tomorrow. I'll record and send you the recording from my machine, that if I change my Nyquist limit to higher side, I'll be reducing my MR jet. If I reduce my Nyquist limit to 40, I'll be increasing my MR jet area.
Okay. Okay, sir.
So that's all you can remember for the time being,
Okay, sir. Okay.
right? Next question of yours.
So that question was not actually related to this topic. Actually, I don't have an eco machine access right now, and I was quite apprehensive that whether just learning the theoretical part of it, will I be able to do like eco just after 3 4 days of hands-on training, or it
No,
feels like quite
it's
impossible
like,
right now.
no. Echo, if you don't have an SS of an echo machine, believe my words, this course is not going to be fruitful to you.
Yeah.
Where do you work for? Which place do you work?
So it's in Kangra, Himachal Pradesh.
So any machine which you have in your area?
So actually, I'm working in a private hospital. They are
Okay,
planning to get a eco machine,
all right,
but they don't have one right now.
okay. So till that time, I can only say that at least you will be good in knowledge of as far as theoretical knowledge is concerned. But I can assure you that 4 days of a time will help you out the maximum possible,
Okay, okay, sir.
right? Take
Okay,
care.
sir. Thank you.
Take care. All right. So let's go to Dr. Rajan Verma, row number 6. Rajan, go ahead.
Good evening, sir.
Good evening.
Sir, I want to know how we will calculate vena contracta. Do we measure only yellow part, or we have to measure both blue and
The
yellow part?
color between the two leaflets.
Color. Okay. Thank you, sir.
Just let me show you, but fortunately, should have the vena contractor right now in front of you. This is like acquired system is there. Let me switch over to another one. I should be able to show you vena contractor right now in front of you. Well, just, okay. Oh, I think should have it now. Perfect. All right. I've got everything in my armament to show you how do we look for a vena contractor. So I'm going to stop this and look at this pointer over here. Concentrate this pointer, red color. So
Yes,
I'm
sir.
moving frame by frame. So this is beginning of a QRS complex
Yes, sir.
over here. So this is at the end of T wave or some wave is there. Let me show you from where it's originating now. Okay. So it's a systole or diastole?
It's a dastly.
It's a diastole. Now this is systole. This is beginning of QRS complex.
Yes, sir.
Correct. This
Yes,
is
sir.
wide QRS complex is there. So this is almost in mid systole.
Yes, sir.
And if you look at the systole, I can switch off my colors. Just a second. Now this is the leaflet tip through which it is originating. So I'll switch it off. So I'll measure. Somebody asked me how to measure it. Now I'm going to measure this from this point to this point. 0.5. Moderate.
Okay, sir. Sir, means we have to measure only the wall between the two walls,
Two
leaflets.
leaflets, not
Leaflets.
valves, two leaflets.
Yes, sir. Leaflets.
If you
Not with
happen
the.
to, yeah, if you happen to see, uh, how do I tell you? If you go to a village, the doors are there, which are two-sided doors, like two parts of a doors are there.
Yes, sir.
When you close them, those two doors, there's something in between the doors left behind. That is
Yes.
one is vena contracta.
Vendor contract. Thank you, sir.
Dr. Ruchi Sharma, go ahead. 16 number.
Good evening, sir.
Good evening,
Sir,
Ruchi.
so I
Ruchi
could not
Saran,
understand
right?
that. Yes, sir.
Okay,
So there was a slide where we compared the stroke volume in the long axis view and the three chamber view. So
right.
for that long axis view, how are we going to calculate VTI in that long axis view?
No. You have connected to two systems along with
Systems
me.
along with me. Sorry, sir.
You have connected
You
two
have connected two
systems.
systems. Oh, sir, only one.
Only one?
Only
Okay.
one. Okay.
Your voice is
Voice is
ricocheting.
ricocheting. It's probably because of that Bluetooth speaker I've connected
Yeah,
with
yeah.
for the volume.
Something,
Yeah.
something is there.
Something is there.
Yes. You're talking
You're
about this
talking
slide.
about this slide.
No, not
No,
this.
not this.
This slide.
This slide. Yes.
Correct?
Correct? Yes, sir.
Okay. When I'm doing the
When I'm
mitral
doing the
valve,
mitral valve,
I can take
you
annulus
take
from here
annulus from
and the
here and the
pulse wave
pulse wave
by
by
Doppler spectral
Doppler.
pattern to get VTI. That is clear? Is it clear, Dr. Ruchi? Are you able to hear me or you're lost? The speakers
The
are gone.
speakers are gone. Now I can hear you, sir.
Yeah,
Sorry.
yeah, speakers
Yeah,
have come back
speakers have come
again
back
now.
again.
So this is
So
annulus
this is
diameter
annulus
across
diameter
mitral
across
valve,
mitral valve,
and you put
and
a
you
sample
put a
volume at
sample
this
volume at
point,
this point,
get a VTI.
get a VTI. Yes, sir.
Clear?
Clear? This
But
part is clear.
in
But in
LVOT, you'll get
LVOT,
an
you'll get
area
an
from
area
here,
from here,
but you'll get
but you'll get
LVOT VTI
LVOT
in 3
VTI
chamber or 5
chamber or
chamber,
5 chamber.
not in this
Not
loop.
in this. Then it's clear, sir. That's what I was
Okay, right.
thinking. How is this? So another thing, a very silly question. I just wanted to ask: when we take that recording of 2-3 loops of cardiac cycle, so
Okay.
how do we get that, sir? That recording, like real time, I can see, but to get that recording so that you can scroll through systole and diastole.
This is a button on
This is a button on
machine
a machine
which helps you
which
doing
helps you
that.
doing that.
You bring back
You
that
bring back
loop,
that loop,
freeze it,
freeze it,
and then scroll
and
by
then scroll
trackball.
by trackball. Okay. And
In
sir,
case
for
you have a
that
problem,
reason,
give us a call in
give us a
the
call in the
afternoon,
afternoon,
and we'll
and
go on a
we'll
video
go on a
video mode,
video
and
mode,
we'll show you
and
how
we'll
to
show
do
you
it.
how to do it. Okay, sir.
Okay?
Thank you, sir. Yes, sir.
Okay, right. All right, Dr. Ruchi is done. Next is Dr. Rafat, online 2. Rafat Zahan, if I'm correct.
Good evening, sir.
Good evening.
Sir, I want to know measurement of pizza in MR.
Rafat, are you doing echocardiography already? I'll show you. I have not shown
Yes,
you
sir.
deliberately the pizza, but let me just show you if he asks me. Absolutely no objections for that. So what we normally do is, what is pizza? Pizza is price proximal isosurface, isovolumic surface areas. So the guidelines for doing pizza is what exactly we are looking. We are looking at the pizza of this surface. Like this is what we are going to measure. Correct? And this what is the basic principle is, we move the baseline towards in the direction of jet. Suppose this is 60, this is 60. So we'll move this baseline up. This becomes a pizza velocity. And then we calculate pizza radius. Let me just show you how do we calculate pizza radius. I'm trying to show. Yeah, it's working now. Now look at this picture and concentrate over here. What do you see over here? Dr. Rafat, are you there?
Yes, sir. Yes, sir.
So what do you see over here, Dr. Rafat Jan? There multiple rings are present in this picture. Look, this like if you happen to see very carefully, looks like as if we have an early morning rise of a sun, something like that.
Yes, sir. Yes, sir.
Correct?
Yes.
So I'm going to stop this for you and move my frame gradually. Yeah. So what I'm going to measure is, I'm going to measure this first aliasing of a color. The first aliasing of color is only this much. And if I
Orange
go,
color. Orange colors.
yeah, this is what orange color is. That's all. And that's why we move this Nyquist limit down so that we are able to see this hemisphere very clearly. So this becomes pizza radius. That's most important thing is. Once we get a radius, we calculate pizza area. That's 2 pi r square into radius. Then velocity of aliasing. So this is, look at this Nyquist limit. This has gone down. So this is Nyquist limit is minus 20, minus 30. And that you get a regurgitant flow. Regurgitant flow divided by the peak velocity of a regurgitant jet velocity. Like suppose it's 4.5, 4.6, we get effective regurgitant RFS area. If you really ask me, I rarely I use this because too much of a calculations. Look, first I'm calculating radius, velocity aliasing is fixed, regurgitant volume, then peak jet velocity. And the most cumbersome part is to calculate the radius of the patient, of this pizza radius. And this is 0.5, 0.6 centimeters. And invariably, lot many people, they depend on pizza. I'm not saying no. This is how we do it. But instead of pizza, what I normally do in my life is I like to go in 3 dimensions. This is one picture I wanted to show you. Look, this is changes with the pizza radius. Now the pizza radius 20, 30, 40, 50, 60. 20, 30, 40, 50, 60. So this pizza radius makes a lot of difference in a clinical practice. So what we do normally is, if I have to look at the severity of mitral regurgitations, I'll just look at 3D vena contracta. So what I'm going to do is just put a cursor at the tip of the leaflet of the mitral valve, calculate the area. And this area gives me, if it's more than 0.4 centimeter square, it'll give me a severe mitral regurgitations. This is what our second, I can go in 3 dimensions vena contracta. Now this is easy. I can go to a loop and calculate the width as well as the depth. And I can calculate this vena contracta in 3 dimensions. And believe my words, the most important thing, if you can do correctly, is the things I've told you. Mitral aortic velocity ratios, flow reversal. What exactly ultimately we are looking at vena contracta is again regurgitant volumes. Mitral elastic Marvin, then this regurgitant volumes, but direct continuity equations. And you still want to do it pizza, that's how we do it. But I spend more time in doing in this particular fashion of mitral regurgitation. 3D vena contracta, or I can go just in 2 dimensions to look for a vena contracta. Okay?
Thank you, sir. Thank you very much.
Thank you. Roll number 7, both, and online, on-site. Dr. Praveen Kumar Tasir. Praveen, are you there? Zero 07. He is not there.
Hello, yes, good evening, sir.
Good evening. Go ahead, Tasir.
Sir, I message my question, sir.
Your message, your
Uh,
question.
Sir, like Nyquist limit concept, same for all regurgitation like mitral, tricuspid.
All,
If we
everything.
change the
Only one place where
yes,
we
sir.
change the Nyquist limit is when we are looking at pulmonic venous flow, where they make it 20 to 40, or hepatic venous flow.
Yes, sir.
Otherwise, remain the same.
Thank you, sir.
Dr. Varun Gupta, 42.
यस सर, गुड इवनिंग सर.
Good
सर
evening.
मेरा क्वेश्चन ये है कि सर जैसे कि हम लोग जो लीजन्स को देखते हैं अलग अलग व्यूज में, पैरास्टल लॉन्ग एक्सिस व्यू में, शॉर्ट एक्सिस व्यू में, तो जो हम क्वालिटेटिवली असेसमेंट करते हैं एलए का साइज बढ़ा हुआ है, एलबी का साइज बढ़ा हुआ है, वॉल्यूम ओवरलोड है, उसके अनुसार भी हमें पता लग जाता है कि सीवियर लीजन हो सकता है. पर सर जब जेट इसेंट्रिक होता है तो सर जो वेलोसिटी जो हम एस्टिमेशन करते हैं वो एक्यूरेट नहीं हो पाता है. तो सर आपकी एक स्लाइड मैंने इसमें देखी थी, उसमें आपने सीवियरिटी ऑफ द एमआर अकॉर्डिंग टू वेलोसिटी लिखा हुआ है. तो उसमें लिखा हुआ है कि अगर एमआर सीवियर होगा तो वेलोसिटी कम हो जाएगी. जब सर एलबी कॉन्ट्रैक्शन कम होगा तो उल्टा वेलोसिटी कम हो जाएगी. तो
Correct.
ऐसे केसेस में सर इसेंट्रिक जो जेट है तो उसमें हम लोग एक्यूरेटली कैसे पता लगा सकते हैं अपार्ट फ्रॉम क्वालिटेटिव असेसमेंट कि वाल्व जो रिगर्टेशन सीवियर है कि नहीं.
उसका वीना कॉन्ट्रैक्टर चेक कर ले. First important point and second important point is look at its pulmonic venous flow pattern.
जी सर. सर वेलोसिटी सर जैसे हम जो ट्रेसिंग करेंगे जो कलर टॉपलर की पल्स
एरिया
वेव.
एरिया ट्रेस करेंगे तो
जी
एरिया
सर.
कम होगा.
एरिया
राइट.
जी सर. जी जी. तो सर जैसे इसेंट्रिक जेट है तो उसमें एक्यूरेटली हम एस्टिमेट कर नहीं सकते मेरे अनुसार सर.
नहीं कर सकते तो वीना कॉन्ट्रैक्टर करिए, बिल्कुल क्लैरिटी दिखाई देगी.
अच्छा सर, ठीक है सर, ठीक है
But
सर.
what exactly, Varun, is the important answer is whether my MR is severe or non-severe.
जी सर.
Take my words, whatever happens in the world, the only few condition when you have an acute MR, your LV would be normal in size.
यस सर. यस
Rest
सर.
all it will be dilated.
जी सर. जी सर.
Correct. In acute MR, when your LV is normal in size, so you can present that patient is presenting with sudden onset breathlessness and a severe MR is present.
जी सर.
So LV is if it's dilated and if see happen to see MR, go for a Nyquist limit, go for a regurgitant volumes. I just told you by LVOT and mitral valve VTI, and look for a pulmonic venous flow pattern.
जी सर. जी सर.
Don't depend only one factor to say mild, moderate, or severe.
जी.
Majority of time when it is severe, then only we put all these questions together. When it's mild to moderate, we are not really bothered. Suppose my LV is normal in size. I see a small jet of MR. I'm not really bothered. When the patient really comes for MR evaluation, then we have to spend time.
जी सर. ठीक. थैंक यू
If
सर.
I'm looking at acute MI, I'm looking at MR. I'm hardly bothered for that acute MI with MR.
जी सर. जी सर.
Correct?
जी.
और
थैंक यू
फिर भी
सर.
करना है, आप साइज देखो, pulmonic venous flow pattern देखो, mitral aortic velocity integral ratio देखो, and then you can calculate this regurgitant volumes.
ठीक. जी सर. जी सर. जी सर. थैंक यू सर.
Right. Now next is roll number 26, Dr. Gisele De Silva. Gisele De Silva, right? No. 26 is Dr. A. Swami. Dr. A. Swami from Jad Cherla, Telangana. Go ahead, Dr.
Sir, good
Swami.
evening, sir. Yeah, sir.
Good
Good evening, sir. Sir, when will measure vena contractor, sir? During mid-systole or at what time, sir?
Mid-systole.
Okay. Thank you, sir.
Very short question, very quick. Thank you. Then roll number 21, Dr. Kamal Mahadev. Kamal
जी
Malia, Indore.
yes sir. Sir, as you set the request limit from 50, 60 to 20, what does that mean? I cannot understand. How do we assess that it is to be drawn to the 20 or drawn to the 40?
At your at
How
your
we
level,
assess this all bit?
keep your Nyquist limit between 50 to 60.
Okay,
Make it a simple formula. For where do you work in Indore, Dr. Kamal?
sir, I'm working in just by nearby Indore, in Badwa.
Badwa. Okay. You have an assessor machine?
Yeah, some of the times
Okay.
I have in other hospital we have, so I go
Okay.
to there to perform echo.
Okay. Okay. Perfect. Perfect. All right. Next, Dr. Tushar Agarwal, 25.
सर
Ludhiana.
मेरे को लाइक जैसे वो एक डॉक्टर साहब ने बोला था कि मशीन नहीं है उनके पास, सिमिलरली आई आल्सो हैव द सेम प्रॉब्लम। तो माय डाउट इज कि जैसे अभी ये कोर्स पूरा करने के बाद जो 1 मंथ इन अलग से एक ट्रेनिंग कोर्स है 1 मंथ वाला, वो करने के बाद हमें आ जाएगा, उसके बाद लाइक अगर मशीन ले तो मतलब हम कर पाएंगे?
तुषार, एक छोटा सा बात बोलो। आप क्या करते हो? व्हाट डू यू डू?
सर आई एम एमडी मेडिसिन करंटली वर्किंग इन दिस थिंग इन लोकल हॉस्पिटल इन लुधियाना। We don't have machine right now, but every Sunday I go to some other hospital to practice on my engineer friend. I take my friend with me and I just try to practice on him.
Can I ask you a personal question? How much money do you earn every month?
So right now 2 lakhs per month.
Oh my God. Yeah, even I don't earn 2 lakhs rupees per month. Can't you buy a machine?
Sir, I can buy, like I can
Buy
buy,
it,
but like
man. Then buy it.
the
I
certificate and all.
will help you out. At least start working for buying a machine.
Yes, sir.
I can assure you a machine for hardly 10 lakhs rupees. Invest about 9 you take in loan. Let's say 11 lakhs rupees of a cost of machine. You pay 1 from your pocket, correct? 10 lakhs rupees of a machine. 5 years of a loan, 2 lakhs rupees per year.
Yes, sir.
You are a Gupta Agarwals, right? You know
Yes, yes.
mathematics better than me. 2 lakhs rupees every year means divide by 12. How much comes out to be?
Sir, that I understood, sir. But like just one doubt is like वो हो जाएगा, मतलब like थोड़ा सा डर लग रहा है कि
तुषार, कोशिश कर, सब होगा। ऐसा कुछ नहीं है।
यस सर।
लाइफ में कोई चीज नहीं है जो नहीं हो सकती है।
यस
अगर
सर।
घोड़े पे चढ़ोगे नहीं तो गिरोगे नहीं, गिरोगे नहीं तो सवार नहीं हो सकते और लर्न नहीं कर सकते। और
यस
जिस
सर।
दिन
यस
अपनी मशीन लगा लोगे ना, उस दिन सीखने की जो ताकत है 100 टाइम्स ग्रो कर जाती है।
यस सर।
I don't know what you think in your life. How old are you, by the way?
सर 30 years,
अरे
30।
छा गए, बिल्कुल जवानी का पूरा जुनून है इस वक्त। कर सकते हो तुषार।
ठीक
लुधियाना
है।
में एक बड़े बहुत अच्छे स्टूडेंट हैं, फ्रेंड हैं, फिलोसफर हैं, डॉक्टर आशीष सक्सेना।
ओके सर।
आप ढूंढोगे लुधियाना में मिलेंगे, उनके पास जा सकते हो। नहीं तो डीएमसी में डॉक्टर रोहित टंडन के पास जा सकते हो।
ओके,
और
आई
डॉक्टर,
कंप्लीट।
हाँ, मतलब कई सारे लोग हैं जो लुधियाना में सीख के आए हुए हैं। यू कैन गो टू देम एंड दे कैन हेल्प यू आउट।
थैंक यू सो मच सर।
लेकिन मशीन खरीदना मैंडेटरी है। मैम ने
यस सर।
पूछा
यस
था कि मशीन नहीं है। अरे, अगर हम लाख रुपए महीना कमा सकते हैं तो हम 10 से 20 हजार रुपए की इंस्टॉलमेंट देंगे तो हमारा घर आराम से गुजारा हो जाता
यस सर। यस सर, थैंक यू सर।
है। ओके डियर। डॉक्टर राजन वर्मा, रोल नंबर 6। राजन, गो हेड।
Sir, how please repeat how we measure a regurgitant volume, sir?
Rajan, this is a very simple thing. Look
Yes,
at
sir.
the flow across mitral valve. How do you
Okay.
calculate stroke volume across mitral valve?
We measure area and then
Correct.
VTI.
Area into VTI. Area, how
Yes,
you
sir.
measure? 4-chamber view, annulus diameter.
Okay.
So
Yes, sir.
that's diameter divided by 2 would be radius, pi r square into VTI.
Okay.
Correct.
Yes,
Now,
sir.
how do you measure the LVOT area? LVOT VTI?
LVOT VTI in 4-chamber view.
Three-chamber view. Three, no, not 4. 3 or 5.
3 or 5. Yes, sir. 3 or 5.
Correct.
Yes, sir.
LVOT diameter?
LVOT diameter in plex view.
Correct. So in plex view, get a diameter divided by 2 will give you area.
Yes, sir.
multiplied by LVOT
VTI.
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 So one side you're getting a stroke volume across LVOT. Other
Yes,
side
sir.
you're getting a stroke volume across mitral valve.
Mitral valve.
The difference between mitral flow and LVOT flow. What will happen in severe MR? Less flow will go to LVOT.
Yes, sir.
As soon as the LV will contract, because the MR is severe, lot of
Severe.
blood will go back into the LVOT. Oh,
Yes, sir.
mitral LA.
In LA.
So
Yes, sir.
obviously the flow which is happening with LA contraction would be more in mitral valve than in LVOT.
Yes, sir.
And if the difference is more than 60 ml, you got the answer.
Yes, sir. Okay, sir. Thank you so much, sir.
So everybody clear what I'm talking about? Yes. Dr. De Silva, go ahead.
Yes, sir. Actually, you mentioned that in severe MR, there is a transmission of blood into the pulmonary veins.
Correct.
So the Doppler that is to be applied in across the pulmonary veins, in
Into
which
the
view
pulmonary,
is
pulse rate Doppler into the pulmonary veins.
sir? But in which view I wanted to like apply
Four
the
chamber
fourth
view, four
chamber
chamber
or
view. I'll just show you. Give me a second. I'll show you four chamber view. In four chamber view, here is a pulmonic vein.
okay.
So put a pulse rate Doppler spectrometer not in LA, superior surface, but in pulmonic veins, inside the pulmonic veins.
Any particular pulmonic veins or
Normally, what we are seeing is right pulmonic vein. Left is over here. We keep in left, right pulmonic veins
okay. Okay.
because we are parallel to the flow,
Okay, sir. Yeah. Right.
right?
Yeah.
Okay. Anybody else? Some other questions before I move on to AR? AR, if you have learned MR, AR is not difficult. Same thing. I'll show you like exactly it looks to be same. All right. No questions. Let me shift over to stop sharing. Give me a second. So I'll stop this also. Exit. If you really want to learn echocardiography, it'll be a very useful thing in your clinical practice. And only answer is have a machine. All right. So let me just go to my presentation. Not too much of AR I'm going to talk about, but I'll definitely talk about anatomy, classifications, etiology, and evaluations. So all of us understand aortic valve has got a right cornicus, non-cornicus, and left cornicus. Now, as we talked of a mitral regurgitation, even aortic has got the same issues. We talk of acute versus chronic, primary, and due to aorta disease. In acute, we have endocarditis, dissection, blunt chest trauma. And It could be infective endocarditis is quite a common thing when we look at all these things. Chronic primary rheumatic is very common. Calcification is playing a havoc as on today. Bicuspid aortic valve, systemic inflammatory diseases. AR due to aorta diseases like Marfan's, hypertensive disease, aortitis, familial aortic aneurysms. Then another thing which has come up in our circumstances is newer iatrogenic etiology of chronic continuous aortic regurgitation. Post-LVAD, post-aortic valve balloon dilatation for bicuspid aortic valve, post-TAVR. These are quite commonly seen. Let me show you examples first. This patient has got infective endocarditis of the aortic valve leaflets and will present with what? Acute inflammation will always present with regurgitations. Then here is a patient who just walked into our lab, young boy, 30 years old boy, running fever for last couple of months. And he just walked in and said, I'm having a chest pain. When we did an echo, what is very innocuous? You see a vena contracta is almost 7 millimeters over here. And right coronary cusp is seen, non-coronary cusp is not seen. Now look carefully. There is no cusp over here. Look, LV looks to be borderline dilated. When we measure, it was just 32 millimeter endoscopic dimensions. And when we did a color Doppler, look, this patient has got a severe aortic regurgitation. I'll show you why aortic is. If I hold this picture over here, if I measure this flow across this AR this is vena contracta more than 7 millimeter in size. Vegetations, this patient had multiple vegetation all around. Now, dissection of aorta. God has not given us two aortic valves. God has given us only one aortic valve. If you happen to see two aortic valves, one over here, one over here, think of dissection. It is always associated with AR. And this is a dire emergency. You can't sit down and wait to correct it medically or something like that. As soon as you see a dissection, the patient should go undergo surgery ASAP. It cannot be mild, moderate. It has to be severe only. Now look at aorta is fully dilated. And you could see a flap over here, one over here, one over here. And once you see this flap, obviously the answer is again aortic root replacement. And patient will have a severe MR. Here is the flap over here. You cannot have a better dissection than this. The flap moving in and out of the aortic valve. Dilated aorta. Then this is chronic primary. As we see a mitral regurgitation, here we see a aortic regurgitations. Then unicuspid aortic valve leaflets presenting with AR. Bicuspid, only two leaflets, one on this side, one on this side, presenting with AR. This is bicuspid leaflet. One over here, one over here. This picture was published by General Electricals in their G Healthcare in their international book. Then quadricuspid. Look at this one over here, second, third, and fourth. Four leaflets are there. Severe MR. Look, this is again a vena contracta of a patient. This is vena contracta. You measure from this point to this point and hitting the AML. Then rheumatic. And majority of RHD involved with aortic valve is they are associated with mitral regurgitation. Majority, I'll say 95%. Chronic calcified aortic valve. This is not exactly a degenerative. I can show you lot degenerative aortic valve leaflets nowadays. VSD with AR is like a doubly committed VSD is always associated with the aortic regurgitation. So here we are not doing anything for AR. We are just replacing, closing the VSD. This is what is exactly happening. If you look at carefully, I'll just freeze this film for you. Look, the AR is continuous, systole and diastole, systole and diastole, systole and diastole. This is iatrogenic AR. And why this iatrogenic AR is, the patient has been put in an alveolar over here. So alveolar is what? It's a motor which is installed at the apex of the LV cavity, is constantly sucking out blood from LV cavity and delivering to aorta. So this valve is continuously leaking. Alveolar is over here. You can see this equipment over here. After TAVR, we do see number of time aortic regurgitations. So primary, related to leaflet as was in mitral status. Secondary, chamber dilatations. And features are virtually the same as in mitral regurgitations. In mitral regurgitation, we saw vena contracta, correct? And in aortic regurgitations, let me just show you what exactly aortic regurgitations are. Before that, the most important part of any severe aortic regurgitation is wide pulse pressure. Then imaging of the valve will tell you what kind of valve it is, like if it's doming, flail, prolapsing, thickening, calcification, dilated aortic root, dilated LV cavity. Now, important thing is, as we saw jet area over there, oblique jet area versus LA area, what do we see over here is, we fix the image to calculate LVOT diameter versus jet area at LVOT level. So what we call jet height versus LVOT height. And there it was jet area versus LA area. Here is jet height versus LVOT height. And this is what we do in Plaque's window. And this thing has been devised by none other than Dr. Nanda from US in 80s, I believe. He was a pioneer of developing this technique of assessing aortic regurgitation. He's a person who passed out from Mumbai Medical College, went on to settle in USA, in University of Alabama at Birmingham, close to Atlanta, is about 200 kilometers away from Atlanta. So what he showed you, like you measure the LVOT diameter, all of us, you know how to measure it. Then during early diastole, you measure the jet width height. And if you take this ratio of jet width height oblique LVOT height, that was 20 and 40. Here is 25 and 65. And the jet originates from the leaflet tips. And this is what is vena contracta. Here is jet width height, but here is vena contracta. So 25 and 65. And once you look at this jet width height oblique LVOT height, and second parameter which we always look at is the vena contracta through which the jet is originating. Here is the LVOT height would be somewhere here, but vena contracta will happen at the leaflet tips. And this will happen in diastole, not in systole. Same parameter, less than 3, more than 7. Jet width height, oblique LVOT height, correspond to jet width area will LA area, and vena contracta is the second thing. Third important parameter is go to apical 3-chamber or 5-chamber view. Put a continuous wave Doppler across this aortic regurgitation. What we look is the pressure half time. If the pressure half time is less than 200 milliseconds, it is known as severe aortic regurgitations. And the fourth sign is a collapsing pulse. Put a sample volume in descending aorta. If there's a holodiastolic reversal of flow in descending aorta, it means we are talking of severe aortic regurgitations. VTI 22 and diastolic velocity 22. And sometimes we put in abdominal aorta to see a reversal of flow in abdominal aorta. So if I have to say all these things, if I have to comprise and concise all these things, is plaques window, jet width height, oblique LVOT height. Same window, vena contracta. Same window, LV dimensions during diastole. Then go to 4-chamber, 5-chamber or 3-chamber view. Look at pressure half time, less than 200 milliseconds. And then go to suprasternal window to look for reversal of flow in descending aorta. End diastolic velocity more than 22 or VTI more than 22. And these all will make a difference in calculating your severity versus progressive aortic regurgitations. And look at the first thing, MR, LV dilatation, AR, LV dilatation. Signals, dense, same in MR. Forward flow, increase, same in MR. Jet with height, oblique LVOT height, more than 65%. AR pressure half time, less than 200 milliseconds. Holodiastolic reversal of flow in descending aorta or abdominal aorta, more than 22. Vena contracta, more than 7. They all consist of severe aortic regurgitations. Somebody may ask you again the PISA. The formula remains same, but I don't use PISA in majority of times. And what is the most important thing I always do in this subset of population is look at my flow reversal in descending aorta, collapsing pulse and wide pulse pressure. If my BP is 140/80, I'm sure I'm not dealing with severe aortic regurgitation. Now, you still want to be more now. Use the same calculation of regurgitation volume which you use in mitral regurgitations. Same table, same everything. Now what will happen? The flow across LVOT will become more as compared to the flow at mitral valve levels. I hope all of you understand now. And your regurgitation volume, more than 60. And that's what we use number of times again when we're talking of severe aortic regurgitations. Now, this study was published almost, if I'm correct, 10 to 15 years down the line. Why I always show this study, like it's almost 13 years down the line, 15 years down the line, 27, we are 25, 13 years down the line. What this study showed is 20 cases of aortic regurgitation, they were sent to 20 legends in echocardiography around the world. What were the parameters they were used? LV size, jet with height oblique LVOT height, pressure half time, diastolic flow reversal, vena contracta, CW density. You know what was the outcome of that study was? Almost all people said one parameter which is uniformly acceptable is LV size and a volume index. It should be large to classify somebody as severe aortic regurgitation. Then you can have 2 out of these 3 parameters. Vena contracta with holodiastolic reversal of flow in descending aorta, jet with height oblique LVOT height. If you happen to see 2 of these, 100%, then you are dealing with severe aortic regurgitation. You have to comprise all these things to you again. Clinical evaluation informs symptomatology, valve morphology. Transthoracic echo is a mainstay. Indiscrepancy, forget about it. Refer to next stage. We do 2D strain and stress test. I'm not saying looking at this. Management still hover around surgical valve replacement. But the modality which you need to look at this subset of population is, I have to comprise all this modality. I go back to all these things again and again. If I have to compare with MR, jet area versus LA area, here is jet with height oblique LVOT height. Second is vena contracta, both ideal. Forward flow velocity, both. LV dimensions, both. Then here is a one parameter is AR pressure half time, less than 200. Flow reversal in descending aorta and continuity equation to use more than 60 ml of what? Regurgitant flow. And that's what calculate of aortic regurgitations. Now I'll ask you the questions because it's not a rocket science when we talk about all these kind of things. There's so much of things which are available. I'm not going to talk all those things because when I'm doing an echocardiography for AR, I'm talking of mild, moderate to severe, and then severe. I'll just show you one clip. Like I've always thought of showing this clip to people who are very good in doing echocardiography. So let me stop over here and take up your question. I'm sure all of you must be dead tired by now. Virtually evaluation is as good as MR and AR. They're together. No questions? At least one by somebody. All right, good. Dr. Varun, go ahead.
सर गुड इवनिंग।
Good evening,
सर
Varun.
सर मेरा सवाल ये है कि कभी कभार ऐसा होता है सर, जब एआर भी हो रहा होता है, साथ में मिड डायस्टोलिक मर्मर एमएस की भी आती है, तो उस समय सर हम कैसे डिफरेंशिएट करें?
आप उसको 3 चैम्बर व्यू में चले जाएं और
जी सर।
सेपरेट आउट कर ले। 3 चैम्बर व्यू में एआर का जो फ्लो है वो सेपरेट दिखाई देगा और एमआर का फ्लो सेपरेट दिखाई देगा।
ठीक
एआर का और माइट्रल स्टेनोसिस का फ्लो अलग अलग दिखाई देगा दोनों।
ठीक है सर, ठीक है सर।
और सेकंड चीज, अगर सिवियरिटी ऑफ एआर देखना ही है आपने तो होलोडाइस्टिक रिवर्सल फ्लो डिसेंडिंग एओर्टा देखो।
ठीक, जी सर, जी सर, थैंक यू
वरुण,
सर।
कहाँ आगरा में कहाँ पर हो आप?
सर मैं आगरा में मतलब मैं सर फिरोजाबाद में एक ट्रॉमा सेंटर हॉस्पिटल है, वहाँ पर मैं फुल टाइम काम करता हूँ। शाम को सर मेरी क्लिनिक है आगरा में।
ओके, गुड गुड। कहाँ से पास आउट हो?
सर एसएन मेडिकल कॉलेज से।
क्या बात है, किस ईयर में?
सर 2016 में मैंने पास किया था।
ओके, और
जी सर।
बॉस कौन थे तुम्हारे?
सर डॉक्टर मनीष बंसल सर मेरे गाइड थे।
अच्छा,
और बाकी सर मैं डॉक्टर ए के गुप्ता सर से भी गाइडेंस में लेता रहता हूँ,
ओके।
मतलब कोई भी समस्या आती है सर।
एक और भी डॉक्टर साहब है ना वहां पर, क्या नाम उनका, जो इको भी करते हैं?
सर हमारे समय तो केवल डॉक्टर मनीष बंसल सर है हमारे, मतलब मेरे गाइड थे, वही करते थे। अब तो काफी डीएम कार्डियोलॉजिस्ट आ गए हैं, वो करते हैं सर।
ओके,
जी
चलो गुड गुड। मैं भी वहीं का पास आउट हूँ, 84 का।
जी 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 सर, जी सर, मुझे बताया सर, थैंक यू सर।
ओके,
जी
ऑलराइट,
सर
एनीबॉडी एल्स?
सर
गो अहेड शिखा, गो अहेड।
sir, just like in mitral regurgitation, in aortic regurgitation, we are not grading it as mild, moderate, severe, or means in aortic it is either progressive or severe only.
शिखा, बेसिकली क्या हो रहा है धीरे धीरे, व्हाट वी आर लुकिंग फॉरवर्ड इज वी आर नॉट टॉकिंग ऑफ माइल्ड मॉडरेट सीवियर, वी आर टॉकिंग ऑफ सीवियर और प्रोग्रेसिव.
Okay.
Progressive could be mild, moderate, moderate to severe.
Okay.
Because when we talk of a progressive, we need a medical management. When we talk of a severe, we need a surgical interventions.
Okay.
So gradually things are changing in that particular directions.
Okay, sir.
All right.
Thank you.
Anybody else? So if there's no more question, let me stop my presentation over here and call for my attendance.